check testicular cancers. Where do you find the malignancies? You find them in the you find them in the GU, right? Yeah. In the kidneys, in the bladder, on the penis, the testes, the prostate. That is your GU system, right? In the kidneys, you have two types. There are those that can come from embryonic cells. So they are called nephroblastomas. So the nephroblastomas are kidney cancers that come not from adult kidney cells, from embryonic kidney cells, carried in adult, actually carried in children. Okay, so they are embryonic renal cells that become, the kids are born with them and then they become malignant, usually in children, right? And then adult, we have the renal cell cancers that are also known as hypernephromas. Bladder cancers, even though they call them bladder cancers, transitional cell cancers, you can find them anywhere from the pelvis to the urethra. Even though they're called, they tend to be primarily, predominantly in the bladder. They could be found anywhere from the renal pelvis to the tip of the urethra. So let's take each one of them. Nephroblastoma. Well, Wilm's tumor was first described by Max Wilm in 1899. Like I said, they come from embryonic renal tissues. Why do they persist? They're supposed to disappear after the kidney is formed. You're not supposed to find them. They persist because of these genes. Wilm's tumor gene, Wilm's tumor 1 and Wilm's tumor 2 genes. Those are abnormal genes that are associated with Wilm's tumor. Okay? So the WT there is Wilm's tumor. Okay? What is interesting about these tumors is that they are usually associated with aniridia. Aniridia is the absence of the iris. If you look in your neighbor's eyes, you see that they have a hole in the center of their eye. That hole is what we call the pupil. Okay. It is because of the space between the iris. So the absence of iris is called aniridia. So when you look in the eyes, there's no hole. The whole thing looks like a black hole. Okay? So that is usually your clinical clue to that Wilm's tumor. So if you find a kid with a tender, if I give you, anybody gives you, or you find a kid with a tender lateral or a tender flank mass with absent iris, and I tell you what, is it likely to be hypernephroma, kidney cancer, spleen cancer. You know I'm talking about Wilm's tumor, right? Excellent. So it's a childhood malignancy. It is usually unilateral, but it could be bilateral in 5% of the cases. It presents with abdominal mass that is usually tender and painful. What is the difference between painful and tender?
Tender is like when you painful is always going, right?
Tender is the one you elicit by touching. Pain is the one the patient comes with. Okay. So if somebody comes with abdominal pain and mass, you will say on examination the mass is tender. You won't say the mass is painful. Right? Okay. Pain is a symptom, tender is a sign. Good. And then they have a renal hypertension. So you find it's one of the causes of childhood hypertension. And they could have hematuria. And the hematuria could be macro or micro hematuria. In other words, the patient can come with frank bloody urine, or the blood might be picked up by a routine urinalysis. Okay? So you see aniridia, that's the way the eyes look. How do you diagnose it? Like every abdominal mass, first thing you will do is the cheapest thing, right? You do ultrasound of the abdomen. Then you find that there is a mass on the ultrasound, then you do an abdominal CT or MRI, depending on where you are and what plan your patient has. Okay? But ultimately, you're going to diagnose it with a biopsy. And the biopsy is going to be a percutaneous biopsy. You're going to go through the skin. All right? All right? Then, like every cancer, once you diagnose it, you want to see how bad it is. You do a TNM staging, tumor node and MEX, right? You're familiar with TNM staging, right?
Yes. Yeah.
Good. I'm not going to bother you with the specifics. It's not important. You do the TNM staging to see how far along the malignancy is. And the way you do it is medical imaging. So you might end up doing pelvic MRIs and spinal cord, brain, depending on the stage of the tumor to find out how far gone it is. So you do medical imaging. How do you treat it? Everybody gets nephrectomy. And those with advanced diseases will get chemotherapy on top of that. It's a good tumor to have. If a child must have a cancer, nephroblastoma is a good one because he has 90% 5-year survival rates. Okay? Any questions? That's all you really need to know about nephroblastoma. Okay? Good?
Yes.
Moving on. Hypernephroma. Hypernephroma are adult kidney cancers. They come off of the epithelial cells in the proximal convoluted tubule. So they don't come from embryonic tissue. They come from the epithelial cells in the proximal convoluted tubule. There is a strong association with sickle cell disease. So sickle cell disease is associated, and it says a cause. Associated. Okay. So people with sickle cell disease have a higher prevalence of, hypernephromas than people that do not have sickle cell disease. We know about some things that can predispose you to, if you have a genetic predisposition to hypernephroma, there are some things that may precipitate it. Okay? So if hypernephroma runs in your family, and then you smoke, or you become overweight, or you are diagnosed or treated for hypertension, or you get on dialysis specifically for a cystic kidney disease, your mom, if you live long enough, you might develop renal cell cancer. It is interesting that hypertension has a very strong association with hypernephroma. We can't tell, is it the hypertension itself, or is it the treatment for the hypertension, right? We don't really know, but we know that somehow there is a strong association with hypertension. We still treat patients with blood pressure medicine because you will die of stroke and heart attack before you get hypernephroma if we don't do that. Okay? And again, the patient presents with, again, painful abdominal mass, again, renal hypertension, hematuria, it could be micro or macro. It's exactly the same kind of presentation as Wilms tumor. Exactly the same thing. Exactly the same workup. It's a painful mass. The right flank. The only difference is one is in children, the other is in adult. Okay. And then again, you do an ultrasound, and if you have a positive ultrasound, then you do abdominal CT and MRI. Ultimately, you have to diagnose with biopsy, and you're going to stage with the medical imaging. Again, treatment is surgery, and in advanced cases, you will do not chemotherapy, ablation. You either burn it or you freeze it. Okay, you can burn it with laser or radio frequency, or you freeze it with cryotechnology. Have you guys been taught how to freeze warts?
No.
Not yet? Where are you going to do that? You don't, nobody's, oh, you need to know how to do that. That's so important, man. So many people with warts out there. Okay, well, I'll look into that. All right, so prognosis depends really on the age, the health, where the location, the surgeon, the theater, the PA. So how you do with hypernephroma is really multifactorial. If you have hypernephroma when you're 68 years old, hypertensive, diabetic, on dialysis, surgeons will even look twice before they touch you. Right? If you have hypernephroma when you're 55 years old, healthy, basketball player, everybody will jump to do a surgery. Right? So it's really multifactorial. Prognosis in hypernephroma is not like Wilms tumor. Questions? All right. Now let's talk about these transitional cell cancers. They come from the lining of the ureters, bladder, and urethra. So even though we call them transitional cell cancers, and most people think they're bladder cancers, the truth is that transitional cell cancers can be found anywhere, from the renal pelvis all the way to the tip of the urethra. Okay? So if somebody presents, for instance, with a flat thing, and you examine them and you find tenderness in the right line, and you do an ultrasound, and they say there is hydroureters and hydronephrosis, that the fluid is backed up there. It's not, it doesn't have to be kidney stones. It could be transitional cell cancer of the ureters that is obstructing urine flow and causing the hydronephrosis. Okay? So that is, if anybody asks you what the differential diagnosis of flank pain and a mass, transitional cell cancer should be one of your differential diagnoses. They're mostly in the bladder, but they could be found anywhere from the pelvis to the ureters. Okay? What are the risk factors for transitional cell cancer? They have very interesting risk factors, right? Like every cancer, they have cigarette smoking as a risk factor. There is no cancer that cigarette smoking is not associated with. So one of the most horrible things a human being can do to themselves is to smoke. Really. And I think women should be prosecuted, or parents should be prosecuted for homicide when they blow the smoke in the face of children they're carrying. Because we know it kills. And nobody should get away with murder. Okay. So cigarette smoking is a big deal, but for bladder, for transitional cell cancer, bladder irritation, especially chronic irritation of the bladder. Like if you are from Southeast Egypt, you have schistosomiasis, right? It's an endemic parasite of the bladder. Bus and truck drivers that hold a pee for a long time until they can get to a truck stop. You know you get a ticket if you pee on the road in this country, right? One of my friends got out of the car and he went to Vegas to pee. And the next thing he knew, the highway patrol pulled up. So what are you doing? He said, I'm peeing. I was like, you can't do that. What am I supposed to do? The guy.
They register you as a sex offender. In the middle of the desert? Oh, no, in California.
Oh,
If you're peeing.
Oh.
In California, if you're peeing outside and the cop pulls up and you get a ticket, they register you as
They can't.
Sex offender.
Yeah. Yeah.
Because you're peeing.
People don't know that, yeah.
Because they're kids.
Oh my goodness.
Yeah.
I'm going to tell you just, you got lucky, man. Okay.
California.
So bus and truck drivers that hold their pee for a long time are really at risk for bladder cancer, and it is true. You see more bladder cancers in truck drivers and school bus drivers. Okay? And then chronic catheterization, you know, like MS patients, prostate patients that carry Foley catheter, and the balloon of the catheter rests at the bladder neck, causing chronic irritation. If they carry that up, these kids that get ganglios with gunshot wound to the spine and become paraplegic, many of them prefer to carry condom catheters, but sometimes some not so well informed clinician will put them on Foley catheter. That is so bad, it predisposes them to recurrent infection and bladder cancer because of that chronic irritation. I mean, if that happens to you in your teenage years, which is more likely in gangbangers, then you can carry that Foley catheter for over 20, 30, 40 years, right? You can imagine what that can do down to the bladder. Okay, so that is why chronic catheterization is actually another risk factor for bladder cancer. And then occupational exposures to aromatic amines. Aromatic amines are aniline dyes, paint, and pigments. They all contain aromatic amines. So people that work in paint factories, whether they paint autos or they paint houses, they're exposed to paint and pigments. Even textile industries, dyeing clothes and all this stuff, right? So those are real danger occupations. That is why in your history taking, it is important to know not only what your patient does, but what they've done for a living. Many immigrants come to the United States, and when they're elderly, they become security guards. But they could have been truck drivers, they could have been painters in their home countries. So always ask people not what you do for a living, what other jobs have you held? Yeah, it kind of helps you with the accumulative risk for specific diseases. Okay? And then medications like cyclophosphamide and analgesic. I worry a lot for people with painful conditions. Phenacetin was an old analgesic like Tylenol. Everybody used it way back until we found out that, wow, stop, causes bladder cancer. It's like saccharin, right? Saccharin was this sugar substitute. When it came out, everybody was like, oh my goodness, thank God, now we have the bullet for obesity. And we found out later on that it was causing bladder cancer, right? So there are medications that are known to do that. Phenacetin, of course, saccharin, I should have put on there, but I didn't remember when I was making this slide. How does it present? Present with painful dysuria. Okay? What is painful dysuria? What is dysuria? Okay, good. Dysuria is not pain with this. It's painful dysuria. So patients with, why do they have painful dysuria? Because, well, not everybody will have painful dysuria. You understand that, right? For instance, if the cancer is in the dome of the bladder, they're not going to have painful dysuria, right? If the cancer is in the bladder neck, then they will have painful dysuria. Okay, position A. Position 1, position 2. In position 2, they have to push through that obstruction. And if it is cancer and it's eroding, it's probably ulcerated, right? So that would be pain. So if it is in the dome of the bladder, it will just be hematuria. It may not even have dysuria. You understand? So whether they have hematuria and or painful dysuria depends on the location of the tumor within the bladder. Okay? How do you diagnose it? You have to go in and look. And we have devices now. Cystoscopy and biopsy. Why won't you do ultrasound? David?
Yes.
Why won't you do ultrasound?
You might not see it, or you might not.
Why won't you see it?
Yeah, it's too small.
Ultrasound looks at the bladder from outside, not from inside. If I don't have that door and I'm in the hallway looking, what I see you guys doing, because there's a wall. Ultrasound looks at the bladder from outside, not from inside. So the cancer is inside. So ultrasound will not see it. Because ultrasound is based on waves that come and hit the structure and they're reflected and they create an image. Right? It doesn't give you.
If it was in the ureter, so you could see it, right?
With ultrasound? You will never see anything inside a cavity with an ultrasound. Unless the whatever is inside has a different echo characteristics than the wall of that. What are you talking about? What are you talking about?
No, I was just curious because what about ultrasounds for like pregnancies? How does that work?
Yeah, I was about to explain. If what is inside the cavity has a different echo characteristics, it deals with the waves differently, it will reflect cancer will have the same consistency like the bladder wall. So you will not see it. Just like colon cancer, you will never see colon cancer without doing an ultrasound, right? But if you have fecalite or you have appendix, you might see with ultrasound, because in appendix there is a fecalite that is obstructing the appendix that has a different echogenic shadow from the appendix itself, right? And there might be air trapped with it, and it might be swollen. So the wall might have a different consistency and echo characteristics when you do the echo than the normal wall. In bladder cancer, that does not happen. So you don't do ultrasound for bladder cancer. You do cystoscopy and you do biopsy. Okay? You did radiology with that?
Yeah.
Okay. So that's sufficient. Then TNM staging again for medical imaging. How do you treat it? You do surgical resection. Depending on the extent, you might need to do urinary diversion. So if the entire bladder is consumed by the cancer, you may actually have to take out the entire bladder in a cystectomy and then plant the urethras in a segment of the bowel, right? So the person becomes a bird that pees and poops through the same hole, right? But it has some dangerous side effects because there is a lot of chloride in the urine. When you plant the urethras in the colon, the chloride gets absorbed, right? And once the chloride gets absorbed, it's a negatively charged ion, right? It displaces bicarb and pushes the patient into what is called hyperchloremic metabolic acidosis. That is a medical complication of urinary diversion. Okay. But if the cancer is limited and picked up early, which one will you pick up earlier? Is it the one in the dome or the one at the outlet? Which one are you likely to see earlier? Dome or outlet? Outlet, exactly. Dome will be there until it bleeds. The one in the bladder neck does not need to be very big. It will obstruct, and the patient will come to you with dysuria. You will do whatever you have to do, and then you'll find out that, oh my goodness, there is a mass sitting at the bladder outlet. Yes.
Why would you plant the urethra for taking out the bladder in the colon versus bringing it up to the surface and making like the depth tubes? You know?
You can also do that.
Oh, okay.
And first, there are options. Sigmoidostomy is one option. You can plant ureterostomies on the skin and have a urine bag. There's so many options. That I am not going into the specifics. I'm just trying to describe one technique of urinary diversion. So you just need to know that you will do surgical resection. It could be complete or partial cystectomy, with or without a urinary diversion procedure. Okay, usually that is not your call. The surgeon makes those kind of decisions. There is something interesting. It turns out that if you find bladder cancer very early and you introduce BCG, you know BCG, the same bacillocavage-guerin protein that we use for BCG, and you incubate that bladder with it for like 6 hours or so, you activate the cytotoxic T cells in the same way you activate them for BCG vaccination, but this time they are so lethal to bladder cancer cells. So we also use immunotherapy with intravesical BCG for bladder cancer. Okay, if you find the cancer very early, very early, it could be curative. But more often than not, it is used as an adjuvant after you've taken you resected the tumor. You can now use the BCG to take care of any lingering cancers, MIB. Got that? Okay. And then again, if it's very far advanced, you might need radiation and chemotherapy. Of course, these are not your decisions, right? You refer them to oncologists. The oncologist will sit with the surgeon and the pharmacist, and they will figure out the best thing. Now, across the street, they have tumor boards. I'm actually arranging for you guys to sit on tumor boards and see how these teams make decisions on patients with cancers. The surgeons want to cut, the oncologist say, no, wait. The pharmacist will say, okay, the best way to mix it, give them all this other stuff. It's a team effort. Your goal as primary care providers is to identify it. Once you see the risk factor, look for it. Do a urinalysis. So for instance, what is the commonest cause of hematuria in a middle-aged male?
Kidney stones?
Commonest cause of hematuria in a middle-aged man could be BPH. What is the commonest cause of hematuria in a young adult, 20 to 40? Masturbation. The commonest cause of hematuria between 20 and 40 male is masturbation. Between 40 and 60, being prostate. Okay. All right. So, that is that. Any question on transitional cell cancer? But let me ask you. Yeah, I actually said that to save you. I forgot. So if you find a 35-year-old male school bus driver with hematuria, would you pass it on masturbation? No, because of his risk, right? Okay, yeah, that was the point of this story. Okay. Okay. Penile cancer. Penile cancer. Interesting. They come off of penile skin and soft tissue. What are the risk factors? HIV. HIV. 8-fold increase. 8-fold increase with HIV. If you keep sticking it in the wrong places, you're going to end up with something. Okay? 8-fold with HIV. And then HPV, 4-fold. Okay? What is common about HPV and HIV? They are strongly related to sexual practices. Both of them. Okay? Of course, HPV, you know, HPV will be signaled by penile and perianal warts and intraepithelial neoplasm. It's interesting, right? I got a text this morning. I was sitting in my office, reviewing my slide, and my phone went, pew! And I looked at it, and it was a text from one of my patients. And he says, "Good morning, Dr. Martins. I just found out I have HPV virus, I have discharging blood, and I was wondering if I can come in to see you and get oral test done for the virus as well." And I said, it is more important to screen for it in the service. See the gynecologist instead and keep your regular appointment with me. These are not rarities. These are real life things that you will see. Okay? And sometimes you just need to share information with people and let them know what they could be doing to themselves. Okay? Again, irritation of the penis is another risk factor, right? For penile cancer. What kind of irritation? See, uncircumcised male, they have these glands in the skin of the prepuce, or the prepucial skin, and that secretion is called smegma. If you are an uncircumcised male, part of what you need to do every day is to retract the skin and wash and clean. If you don't, this smegma it accumulates. And when it accumulates, wherever there is water, there will be life. It accumulates. And the next thing you know, bugs cultivate it. Constant penile irritation. Right? And then with the irritation and the body trying to heal itself, the prepucious skin becomes tighter and tighter, and the retraction becomes impossible. And then you're trapped. See what I'm saying? So, what I've seen in life is, if you neglect to do the right thing, given enough time, you will lose your ability to do the right thing. And you will be trapped on a slippery slope, downhill. I've seen it. I can't tell you how many times. I've seen it. I mean, I've seen a patient, and I was like a prophecy when I was talking to her. I'm like, listen, do the right thing when you can. I'm telling you to stop smoking, take your medicine, stay away from sweets, check your weight. You're ignoring me, you get angry when I talk about it. I'm telling you, you're not always going to be able to do it. She said, oh, Dr. Martin is like, yeah, fine. I'll wait 2 more years, I will say the same thing. One day, she walked into the clinic. She used to come by herself, and she would raise hell in the waiting room. And all the patients would be like glaring, standing in the hall with her and go wait in the waiting room because she's just there, creating all kind of havoc. One day she showed up with 2 people in a wheelchair. She could not even speak. And she said she wasn't going to see anybody but me. When I saw the name, I recognized the name, but I did not know what had happened. I walked in the room, and all she could do was look at me and cry. I'm like, I didn't say anything because there were 2 people there. Even if they were not there, there was no point to say anything. Why feel like a dead horse? Right? Because now, not only she can't exercise anymore, she cannot walk anymore. She can't talk. She has had a massive stroke. What is worse? Now she doesn't get to pick what she eats. She now has a nutritionist that gives to her what she's supposed to have. And she cannot even talk to express her dislike for it. Now she has to wait on people to go to the bathroom. She can't get up to go to the bathroom. See, you all go out and come now. You think that is your right? No. It's a privilege. You should live it like you understand what that means. I have seen that so many times. If you know the right thing to do it. You're not always going to be able to do it if you keep ignoring to do it. Many people don't know that. All you have to do is retract the skin and clean it. If you don't do that, then the skin gets scarred down, and then you can't do it anymore. When you cannot do it anymore, now they say you have paraphimosis. Right? Okay, and then penile abrasions. How do you get penile abrasions? How do you get penile abrasions? What are the possible mechanisms for penile abrasion?
Sex.
Like what?
Sipping.
What? Are you kidding me?
stuck thingy
So
on
what is
zipper.
Was very hairy.
No, it was.
This came out.
It was just like the head, just like stuck.
Why? The hair box?
It was going commando and just had to go.
Well, that is interesting. But generally speaking, is when you know many of these sexual practices are addictive, right? Including masturbation. If you masturbate frequently and you lose control of it, you will do it anywhere, anyhow, even in the bathroom, without lubricant, right? Your saliva does not work as well. Okay, so you see, you end up with all these bruises and stuff, and then you see some guys, they like the women to do this crazy stuff with their mouth, and she has stuff as if it's some kind of piece of meat. Don't you get this? She's bruising that thing.
Bruising that thing. My ears feel abused.
The first time I was in New York, I was in Manhattan, right? And I was just fascinated by the buildings and the lights. And you know, New Yorkers are like, they're really crazy people, right? So, I was at the Greyhound station at first. That was where I landed straight from Nigeria. That was in 1991, right? That was where I landed. So I ended up in Manhattan because I just wanted to see what was going on there. And I noticed this. Though the streets and the buildings are so compact, and you see all these little shops, and nobody knows what goes on in there. But I noticed that in the street, all the young men, they had this picture of one woman that was standing like this by the place there, right? And I saw that all the young men would go in that particular space, and they would come out. And then many times when they come out, they lie like, I'm like, I'm sure that's not the bathroom. You know, because the first my welcome to America was the idea of restroom. I was looking for toilet. I said restroom. That cannot be a toilet. People go there to rest, right? Until I asked somebody in the airport, I really need to use the bathroom. They said, that's a restroom. I was like, oh, restroom. Okay. I was looking for toilet, right? Toilet. So I now said, I was curious, right? Let me go see what is in there. And all kind of crazy stuff. Holes where you can stick your dick and crazy stuff. I mean, constant irritation of penile abrasion is a risk factor for penile cancer. Pay attention, okay? And again, cigarette smoking. Cigarette smoking. And generally speaking, you know what's interesting? I also noticed in life, women get punished more when they do something wrong. If a woman and a man commit they both do something they are not supposed to do. Generally speaking, women nature just punishes women more, right? And also, when young people do wrong things, they tend to get away with it. Once you're over the age of 40, and you keep doing something wrong that you know is wrong, you're not going to get away with it much longer. Look, penile cancers is so rare under the age of 50. It does not matter how reckless you've been. We have not seen penile cancers in people under 40. You don't get it. Even though we know that teenagers and young adults are the most reckless sexually, they do have all this crazy stuff, but penile cancer will not come until after the age of 50. Okay? So how does it present? Pain, bleeding, rash, ulcers? Is it every penile ulcer that is a cancer? What is it more likely to be? Thank you. It's more likely to be a sexually transmitted disease of some sort. but it could also be a cancer. That's why if it's not healing in 4 to 6 weeks, you better get a biopsy, because it could in fact be malignant. Okay, so you do a biopsy. Again, you do your TNM staging, and guess what? Surgery, including amputation. Right? Yeah, they cut it out and they put penile prosthesis. Have you seen penile prosthesis? One time I had a patient on the floor. I did not do a good job when I admitted him, because I admitted him like 4:30 in the morning and we're on call. So 4:30 is when you try to get an hour's sleep or so before the round, right? And then during the round, the guy was sleeping, and somehow in his sleep, he had torn his penile prosthesis up, right? So this stuff was sticking out, sticking up under his bed cover. And the attending was like, what is that? We knew it was not erection, because when guys get erection in their sleep, it's pulsatile. You could see the penis doing that. But this stuff was just like that. So I kind of like shook the bed to try to wake him up. I saw he was really sleeping. And then I lifted up the cover, and it was a prosthesis. And I did not even mention that in my history taking. So quickly I just went and added penile prosthesis, you know. But it's interesting, they attach it to the pubic bone, and you can bring it up and put it back. And it's erection forever. But they've perfected it now. Now they got like these plastics, they're plastics really, plastic rods that is inserted, and they put a hinge at the base of the penis. So it's not as obvious, you know. So anyway, surgery and then adjuvant chemotherapy or radiation therapy for advanced cases. I'm sure you don't have any questions on this one. Let's talk about testicular cancers. They come off of testicular tissues, and you know there are many tissues in the testes, right? Seminomas and all these Leydig cell tumors and all that. But just know that testicular cancers and malignant tumors that come from the testicular tissues. What are the risk factors? What is cryptorchidism? Undescending testes, right? See, the reason that the testes are put in the sac, in the scrotum, is because spermatogenesis has to go on at a lower temperature than the core body temperature, right? So heat is not good for testicular tissues. Not only does it interfere with spermatogenesis, it does in fact predispose to cancers. That is why it is better to wear boxers than bring your balls closer to your core. Okay? Then family history is again important, right? Family history. Klinefelter syndrome, you all know what that is, right?
Yes.
Okay, mumps, history of mumps, very important because mumps virus affect the parotids and the testes. Okay. Smoking marijuana is a risk factor for testicular cancer. Okay, very important. Testicular cancer is the only genitourinary cancers, apart from Wilms tumor, that you see in people under the age of 35. It's also the only cancer that is more common in white than black. Okay? Presents with testicular pain and mass. How do you diagnose it? Ultrasound and ultimately a biopsy. And invariably you have to do TNM staging by medical imaging. And how do you treat it? You have to get rid of the testis in a surgery called orchiectomy. Ectomy, whenever you see ectomy, it just means cut off. Okay? So orchiectomy is removal of the testis. If the guy is interested in having children, you have to do sperm banking before you do the orchiectomy. So you can now use the sperm to fertilize his wife's egg so they can still have children even though he may not have his testicles. If it's an advanced case, they might need chemo or radiotherapy. Again, testicular cancer is like Wilms tumor. It has very good survival. 99%. Most people with testicular cancer will survive their cancers. Okay? So these are all preamble. This is the real deal. If there is any cancer you will see, for sure, in the first 5 years of practice, is prostate cancer. So you need to know this one like the back of your hand. The prostate is right there, just below the bladder, and traveling within the prostate is the seminal vesicle duct, the urethra, and the prostate is right here. Prostate cancers develop within the prostate. Okay? I want you to pay attention to how close the prostate is to the rectum. Okay? And I also want you to pay attention to the fact that when you feel the prostate from the rectum, even though we say we're feeling the prostate, what proportion of the prostate can you feel from the rectum?
Posterior.
The posterior, not even posterior half, like the posterior third, right? And truthfully, there are some patients that are so huge and some providers that are so small, with very small fingers, that your finger will not even go through the canal, talk less of touch the prostate. Even with people that have long fingers and can go deep and feel the prostate, you cannot, a normal prostate on rectal exam does not exclude prostate cancer. I need you to understand that. You don't feel the entire prostate with rectal examination, but it's the best thing we have right now. Okay? What are the risk factors for prostate cancer? Age is the strongest risk factor. Greater risk if father or brother have the disease, and slightly higher for men whose mothers or sisters have breast cancer. You see that? So if a man's mom had breast cancer, the man himself is at risk for prostate cancer. Okay? As well as breast cancer, of course. You know men get breast cancer, right? And then African Americans are again at greater risk than white men and Asian men and American Indian. Prostate cancer is usually preceded by these abnormal cells that are described as high-grade prostatic intraepithelial neoplasia. So it doesn't just start, it starts like the dysplasia that then becomes neoplastic. Okay? There is this suggestion from association studies, we don't know for a fact, from association studies that diets that are high in animal fat and low in fruits and vegetables predispose you to prostate cancer. Okay? So high fat, low vegetables predispose you to prostate cancer. How does it present? This is where I want you to pay attention. Prostate cancer presents with two basic symptoms. No, two basic sets of symptoms. Symptoms related to the enlargement of the prostate and symptoms related to the spread of the cancer. Very important. Enlargement of the prostate and spread of the cancer. Enlargement of the prostate by itself is not cancer because there is benign prostatic hyperplasia. It is the enlargement plus the spread that makes you think of cancer. So what are the symptoms of prostate enlargement? Collectively, we refer to the symptoms of prostate enlargement as prostatism. Okay? So prostatism consists of dysuria, So urination is difficult and maybe painful. Abnormal flow. So the guy pees and the stream is interrupted. Okay? And the stream is very weak. So the man is peeing and the pee is coming out like, okay, a 40-year-old, so 60-year-old man is peeing and the pee is coming out like the pee of a 6-year-old in caliber. Okay? This narrow stream, weak stream. And then every time they finish peeing, they feel like they have to go again because they are not able to completely empty the bladder. And the reason that is the case is because when you have a bladder outlet obstruction, and you push, you will get more urine out the greater the pressure head you have. Okay? As the pressure head diminishes, they're not likely to empty. So they always carry high residual volume in their bladder. So you tell them, so what urologists do is they tell the patients, go and pee. And when the patient comes back and says they are completely done, they now come and they catheterize them. And you see they have a high residual volume. That high residual volume is how you confirm that the patient has incomplete bladder emptying, right? And they tend to pee more at night. For some reason. Nobody can really tell us why that is the case. Why do prostate folks pee more at night? I don't know, but they pee more at night. And then there is this thing called hesitancy. Hesitancy is the fact that they have to wait to start. And the waiting is because they have to somehow, it is not easy for you to increase your intra-abdominal pressure and release your pelvic floor muscles at the same time. Women have to be taught this. Some women, not all women. Specifically, you know about Kegels exercises, right? Good. It is not easy even to relax your pelvic floor muscles. Now, a man with prostate has bladder outlet obstruction. He has to learn to increase his intra-abdominal pressure and release his pelvic floor muscles so he can pee. So it takes him time to do that. So he gets to the bathroom and he has to wait to start. That waiting to start is what we call hesitancy. So it looks like he's hesitating to pee or not to pee. That is not really what is happening. He's getting ready to pee. Okay? And then there is something called terminal dribbling. You see, when a normal male goes to pee and you listen, you hear 3 drops, he's done. When a guy with prostate goes to pee, you hear the pee doesn't stop like it should. It goes, then it weakens, then it drips, then it drops, then it stops. So that is what is called terminal dribbling. And that is why you see the guy comes out of the bathroom because he didn't, especially if he's listening to a lecture, he has to come back in. The pee will now drip inside his pants and you can see, oh man, you saw yourself. Say, yeah, you know, why are you walking like that? Right? Yeah. So it is called terminal dribbling. Okay? And terminal dribbling just means they have to wait to stop. If they wait sufficiently for the dribbling and the dropping, they will be fine. But many times it takes a long time. So they're in a hurry to leave and they end up soiling themselves. Now, when you have prostate cancer, you do not just have a large prostate, you have the spread too. So now you have blood in the urine. And And because the prostate also is connected to your seminal vesicle, and the seminal vesicle is the organ that supplies the fluid that suspends the sperm cells. So you get blood in the sperm called hemospermia. And because prostate cancer has a way of spreading to the bones, it has a specific predilection for spreading to the bones. And you know the bones are formed in the bone marrow. Blood is formed in the bone marrow. As you age, blood formation moves from the appendicular skeleton to the axial skeleton. So in children, they form blood everywhere. Over the age of 40, much of your blood is formed in the axial skeleton. So when you have prostate cancer and it spreads to the spine, it compromises the ability of the patient to form blood in the bone marrow. So most of the time, shortness of breath in prostate cancer is not due to lung metastasis. It's most often due to marrow metastasis and anemia. You got that? Good. And again, because of the metastasis, they got pain in the pelvis, in the hip, in the back. And when the nerves are compromised, they get paresthesia and they get paralysis. All the time they will get erectile dysfunction and ejaculation becomes painful. Okay? How do you diagnose prostate cancer? You do the biopsy. But in order for you to convince somebody that you know what you're talking about, you have to do a rectal exam. Rectal examination for prostate. This is becoming so unpopular now, right? In the clinics, people don't like to do rectal exam anymore, and for good reasons. People get sued for doing what they're supposed to do to help people. So nobody is doing it anymore. I don't do rectal exam. In fact, I've not done a rectal exam. I shouldn't tell you this, but it's true. I've not done a rectal exam in over 10 years. I ask questions, and if it looks like it, feels like it, I send them to go get a rectal ultrasound. Because why do I want to? You know why? When I stopped doing it, when I finished residency, I got a job at THE clinic, right? I was a young physician, and I was medical director. There was a doctor there, Dr. Brooks, Warren Brooks. When I got there, he was 80 years old. This guy left medical school before I was born. So he was still practicing medicine, healthy. I mean, I really admire him. One day, we were just there, and we got the mail. He's been sued for inappropriate sexual touching or something stupid like that. It came from the California Medical Board. And I was looking at it. I saw the name of the patient. It was this 16-year-old kid. And I was medical director, so I called the kid and said, so tell me what happened between you and Dr. Brooks. He said he touched me. Touched you where? He touched me in my belly button. He touched you in your belly button. Did you have your panties on? He said yes. Was there somebody else in the room when he was examining you? Yes. How else was he supposed to examine you for a pelvic pain without touching your belly button? I don't know. She sounded so dumb on the phone. And yet, you know what? Even though the case was thrown away, it was on Dr. Brooks' record that he was accused of that. From that day, I made a decision not to touch anybody below the belly button. And I've not done it. I told them, you want me to continue seeing patients here? I will not. Get your GYM folks to do all that. For my guys, I will take the right history, probably will defer. If I have to have them stick their own finger in their rectum, I'll do it. Right? But I'm not going to do rectal exam. I could do that because I've been around for a while. You just put up with it for a while. You know, you can say, but be careful. It's just not, it's something that is so, you need it, It's not as useful. I don't know why we're doing it. No study has proved that rectal examination saves life or picks up more cancer than anybody than just sending them for PSA and doing transrectal ultrasound. We have no record. Yet the risk is increasing every day of you getting damaged, your reputation getting soiled by some stupid person that is just looking for who to take advantage of. So be careful. So if you're not going to do rectal examination, but you're really concerned about somebody's prostate, do a rectal ultrasound. You see, the ultrasound technician is never going to get sued for assaulting anybody because you are going to get a rectal ultrasound, right? You know from the name of the test that something is going to go in your rectum, right? So, get a transrectal ultrasound trust, right? It's not a good test, it's not the best test, but at least it's a good screening test, okay? Because it has very poor tissue resolution. Look at the way a prostatic mass looks on the transrectal ultrasound. This is the probe in the rectum, the echo, and see how the prostate looks. It's supposed to be uniform like that, right? So when there is a mass there, you can see it, right? If you now think that there is something there, to get better resolution, you do prostate MRI. And see, with the prostate MRI, you see the prostate really well, and you can see exactly where the mass is, okay? But that is not how you diagnose prostate cancer. You see it now. Now you have to prove that it's really a cancer, because that could be prostate abscess, right? Then you now have to do a prostate biopsy. You know, for all cancers, all you need to do is get the biopsy. It is only in prostate cancer that the character of the cancer cells matter. The way they look. In other words, are they angry? Are they just hanging out? Matters. That assessment of the aggressiveness of prostate cancer cells is measured by something called Gleason scoring. So it is not enough for you for lung cancer, you get lung cancer through a biopsy, a specific type, you get a diagnosis. For breast cancer, a specific type, you get a diagnosis. For prostate cancer, it's once cancer, but the aggression of the tumor cells varies from when it is well differentiated, they are behaving maturely, or undifferentiated, they just behave like a bunch of unruly kids, right? So that's great. It's important. So whenever you send anybody for prostate biopsy, it's not done until you get the Gleason score. Okay? Because the Gleason score is what tells you whether you have well differentiated or poorly differentiated anaplastic. Anytime you hear anaplastic, just remember anarchy. Okay? It's restless, lawless community of cells. That is the worst kind. So Gleason score goes from 1 to 5, depending on whether the cells are well behaved or they are totally unruly and malignant. Okay? So after that, you now stage the cancer. And prostate cancer staging is so easy. Stage 1, the cancer is in one lobe. It is completely contained in one lobe. Stage 1. Stage 2, it has involved both lobes. Right? Stage 3, it has breached the capsule. And stage 4, it has gone past the prostate. Okay? So that is how you stage it. And that is how you score it. You Gleason score and you stage, TNM stage. Okay? And then you now put it all in a risk stratification profile. So If your PSA is less than 10 and your Gleason score is less than 6 and you are still within the prostate, that means your clinical stage 1 or 2, then you're considered low risk. If PSA is more than 20, your Gleason score is more than 7, and you have already gone past the capsule, you are considered high risk. If you're in between those numbers, you're considered intermediate. Why is this important? It matters because in prostate cancer treatment, we don't treat all prostate cancers. We have to risk stratify. We look at life expectancy, probability the patient will survive the surgery. We put everything into consideration. So there are three levels of management. For those that are low risk, you do what is called expectant management. Expectant management. What is expectant management? Expectant management means you expect to do something or not do something. There are two types of it. There is the watchful waiting. Watchful waiting means you don't intend to do anything. So this is like 85-year-old, hypertensive, diabetic, history of chronic kidney disease, status post 2 MIs, carries a stent, now has PSA of 6, Gleason score of 4, and the prostate cancer is stage 2. Would you take him to OR? No, you wouldn't. Right? So that one, you see it, you use it for your intent in watchful waiting is palliative. Just help him be comfortable. Give him some Viagra, give him penile prosthesis if you have to. Do whatever you have to make him comfortable. Your intention is palliative intent. You don't intend to do anything else. You can give him tamsulosin to relieve the obstruction, and you can give him finasteride, Proscar, to shrink the prostate. Proscar is an 5-alpha testosterone receptor blocker, right? It shrinks the prostate. So you can shrink the prostate, you can give tamsulosin, both of them do the same thing, to relieve the obstruction, but that's it. The second type of expectant management is active surveillance. This is when you find a 50-year-old male physician assistant now with prostate cancer. It's low risk, but the guy has a long time to live. You don't know if the cancer will stay low or the cancer will become aggressive. Then you do active surveillance. Active surveillance means you intend to go after that tumor if it changes his mind. So you have a curative intent, your patient is young, you do aggressive monitoring. So you do serial PSAs, you even have to do, if you have to do serial biopsies, you do it. Both of these are options for low risk patient. Expectant management is what you do. Either watchful waiting or active surveillance. Your intent is what differentiates the two of them, okay? Now, for intermediate risk, the patient's choice. You discuss with the patient. They can get surgery when the prostate is taken out, or they get radiotherapy. And in that radiotherapy, what they do is they get this, it's very painful. My patient was describing it to me. They get these rods, the radiation source is put in this rod. They implant the rods in the prostate, and they blast the prostate locally. And then they take out the rods. What makes it painful is that when they're inserting the rods, they insert the rods under anesthesia. But when they're taking them out, they take them out under conscious sedation. So patients feel pain, and they sore for days afterwards, because they have rods in their prostate. How does that even feel? All right, so that is for intermediate risk. Now, for high-risk patient, in other words, your cancer is already gone past the prostate, you have to castrate the patient. Why? Laws, why? Now, when I say castrate the patient, we're like, is the patient I'm castrating? Right? So it is castration. There are two ways you castrate patients. The easiest way to do it is surgery. Just take out the testis. They used to do it in ancient times, right? To have guys that sing, you want them to keep their voice. The kings used to have the guys castrated, take out the testicles, so that they maintain that good young voice to sing in the palace for the kings. Incredible what you can do when you have Trump's mindset. Okay, so that is archaeectomy surgically. But medically, there's a way you can castrate too. The way we do it with medical castration, we use the luteinizing hormone releasing hormone agonist. Luteinizing hormone releasing hormone agonist. Where is Tolu?
She texted, she said she didn't know her texting me.
Okay. All right. So, you do this LH-RH agonist. Let me ask you something. How do you think, Vinny, that LH-RH agonist will castrate? Because it's going to stimulate the release of luteinizing hormone. And luteinizing hormone is supposed to help stimulate the testicles, right? To produce testosterone. How then do you give LH-RH and expect it to castrate the patient?
The negative feedback.
How does it work?
Walking the. Forgot the.
I keep having to remind you guys, remember, LH release is a pulsatile release. It's not constant, it's pulsatile. So the receptors are used to that pulsatile release. It comes and it goes. They are not exposed to it consistently. When you give the patient LH-RH agonist, you expose the receptor to constant stimulation. What would the receptor do? It would downregulate. That is how it works. So the constant exposure to LH-RH causes downregulation of the androgen receptors and then results in the castration. Okay? And the example of an LH-RH agonist is Lupron. More commonly now we have Zoladex, very expensive medication by the way. You can also do androgen receptor antagonist like Xtandi and Casodex. That is enzalutamide and bicalutamide. Or you can use the androgen synthesis inhibitors like abiraterone or Zytiga. And of course, after castration, your patient has what is called castration-resistant prostate cancer. Then you now go to radiation. Now, this radiation is external radiation. It's not brachyradiation. Brachytherapy is the one with the rods, local zapping of the organ. External beam radiation is when you put the patient in the chamber and you expose them to that portion of the body to the radiation from outside. You got that? Okay. And then immunotherapy also works, but not with BCG, with other antibodies, biologics, they call them now. Okay, those immunoglobulins. Excellent. See what happens when you take a man and you castrate him. ADT is androgen deprivation therapy. Is the fancy name, is the new name for castration, because castration just sounds like brutal. So now we call it androgen. So you don't go tell your patient, well, your prostate cancer is very, very advanced, so we're going to have to castrate you. That doesn't sound nice coming from a doctor, right? So you say, no, we'll use androgen deprivation therapy. They'll ask you, what does that mean? Castration. It's, when you take a guy's testicle away, he becomes tired, he loses interest in sex, he can't even get erection, he starts getting hot flashes, his arteries get really stiff, he will start to lose bone strength. These are things that will happen to him, but structurally, right? But then you have all these metabolic side effects. His body habitus will change, his lipid profile will change. His body apparatus will change because he will start accumulating abdominal visceral fat. His lipid profile will change. He becomes insulin resistant. He will develop type 2 diabetes. He will end up with metabolic syndrome and he become a high risk for cardiovascular disease. Okay? Very important, very bad thing. Right? Prostate cancer does not have good prognosis, but it's getting better. In the last 10 years, the number of new prostate cancers are falling by about 5.8 per year over. And the survival rate, though, has gone up from 66% in the mid-70s now to about 99% actually, because of all these screenings and treatments, radiation, and all these different ways of castrating people, right? 11% of men are affected by prostate cancer at some point in their lives. So 1 in 10. 1 in 10 male, if they live long enough, will have prostate cancer. 79% of the cases are caught before the cancer metastasizes. That is why the survival rate has improved. Okay? What then is the problem? The problem is the test itself. The PSA test. If you do PSA testing among 100 men, you will find 3 cases of prostate cancer. You will miss 2 cases of prostate cancer. In other words, prostate cancer will be there, but the test will be normal. Okay? And then the test will suggest cancer where there is none in 4 of the 10. So if you use PSA by itself, you will do 3 people good, but you will hurt 4 people. So for every 3 lives that you save, you will subject these people to tests they don't need. You will increase cost, and some of them might die. Because all those tests you're doing, prostate biopsy and stuff, people believe complications do happen. This is the reason PSA is so controversial. It is the reason we can't have the guidelines unified. Because of this behavior of PSA test. But it's gotten a little better. The current PSA test that you must know everything about is, you need to know that normal PSA varies by age and race. And this table tells you, you see, even though we say it varies by age and race, not a whole lot, right? Among Asians, goes from 0 to 2 to 0 to 5. Caucasians up to 6.5 in their 8th decade, right? So it's not a whole lot, but generally it varies by age and race. Just need to know that. Now, PSA itself, the prostate-specific antigen that I will describe a little later, I should have, where's that slide? Where's the slide for PSA? Okay, maybe somewhere. Where's my slide for PSA? Oh, okay, I didn't talk about this. Prostate-specific antigen is the epithelial cell product of the prostate. Its function is actually to dissolve the coagulum and the cervical mucus to encourage the sperm to penetrate it. Okay? I didn't talk anything about this at all. I skipped it completely, and it was in my mind. So PSA is elevated in many prostate diseases, including cancer. So elevated PSA, as a matter of fact, if you do PSA after rectal examination, you'll be elevated. If a guy has prostatitis, inflammation, you do PSA, you'll be elevated. So PSA is not specific for prostate cancer. Okay, that is important. I totally missed that, and nobody reminded or noticed. If Tolu was here, she would have noticed. So, I'm not supposed to talk about this without that. I remember that. Okay, fine. PSA itself comes from the prostate It circulates in two forms, in a free form and in a bound form. The free form account for, listen carefully, more than 25% of the circulating PSA, okay? And the bound form, complex to alpha-1 anti-chymotrypsin, accounts for less than 75% of the circulating PSA. Why are those percentages important? Because a high total PSA with a lower percentage of free PSA is associated with a higher risk for prostate cancer. So if somebody calls you, say, my doctor just told me my PSA is elevated, your next question should be, what is the percentage free? If the percent free is less than 10, 56% chance that that is prostate cancer. But if the percent free is 30, you're okay, probably age rated. You have any problem with urination? No? Fine. You can console the patient. But you cannot say that if you don't know what the percent free is. Okay? So when should you really do something about PSA? If you feel something on rectal examination, you must follow it up. If your total PSA is elevated, and if the rate of elevation is more than 0.75 nanogram per mil per year, so somebody's PSA was, say, 5.0. Now, I say, okay, fine, we'll do it again next year. And the next year again, it was 5.2. Whoa, that is a significant jump. You worry about that, okay? Then, when you do transrectal ultrasound and it's positive, you have to do something more. You cannot sit on that. Okay? And now there is this other thing, it's called pro-PSA. Pro-PSA is a subset of free PSA. They now put it in an equation and they compute what is called the prostate health index. And that is, FDA just approved that maybe a couple of years ago. It's not very popular yet. So we're all still doing PSA and percentage free PSA. And that's what we're using to make clinical decisions in patients with prostate problems. Okay? Why do we have issues with prostate PSA screening? Look, that's the table of controversy. This PSA blood test, this is for your information. PSA blood test, prostate cancer screening for men with life expectancy more than 10 years, asymptomatic, age dependent on risk levels, monitor prostate cancer during and after treatment. What is wrong with it? PSA level can be increased by other factors beside prostate cancer. If the guy is gay and he comes to you right after sexual encounter, his PSA will be elevated. Okay? If the guy just had sex with his wife, also his PSA will be elevated. If he has prostatitis, his PSA will be elevated. Okay, so that is the problem. And then percent free does not have a cutoff point. The 25% cutoff point we're using now does not have any strong evidence for it. It's random. Okay? PSA velocity, well, American Cancer Society does not even think it works. So I just gave you this table so you know, and I gave you the reference, so you know that yes, PSA is not the best test, but at least you can learn how to use it to make the right decision and guide your patient and give them proper advice when they come to you. Any questions? No? All right, let's do some questions. So which of the following genitourinary malignancies is associated with congenital abnormality depicted below? So what do you see here?
No pupils.
No pupils. What do you have?
Nephro.
Thank you. So this 45-year-old female with a history of kidney stones and chronic constipation presents with a constant dull abdominal pain. So that tells you it's constant and it's dull. When the pain is constant and dull in the abdomen, that means it's coming from a solid organ, right? Liver, kidney, spleen, or lymph node. If it's constant and dull. If it is colicky, it's coming from a hollow viscous. Biliary tract, GI tract, ureters. Okay? So the fact that it's a constant dull pain means it's a solid organ pain. Okay? That puts it right there, either liver or kidney, right? Physical examination is significant for elevated blood pressure and a small tenderness in the left flank. Well, this liver is not in the flank. So now we have only one organ. Exactly. It says no demonstrable free fluid in the peritoneal cavity. The initial laboratory test is unremarkable except for serum calcium of 15. Which of the following is most likely diagnosis in this patient? Kidney cancer, exactly. Right? Why do you think he has hypercalcemia?
Because it's not excreting.
The PTH related peptide, right? This is the way your questions will come. Fair question, right? Good. Let's match this. So these are risk factors. These are malignancies. Sickle cell disease. Okay. BRCA gene. Prostate. Human papillomavirus. Penile. Mumpoclitis. Aniline dyes. Sickle cell. Good. Which of the following is not a symptom of an enlarged prostate? Lumbago. What is lumbago?
I don't know.
Back pain. Okay. Lumbago is back pain. It's not a sign of enlarged prostate. It's a sign of spread. Spread. Cancer spread. Okay. So if the guy has terminal dribbling and a new onset back pain, you're probably dealing with prostate cancer. That is enlarging his prostate and already gone to his spine. You got that?
Yeah.
All right. How about this one? What is the most logical next step in the evaluation of this 56-year-old Egyptian truck driver with a childhood history of schistosomiasis who presents with gross hematuria? What are you going to do? What would you do, David? Cystoscopy, good. Because you're thinking this could be bladder cancer, right? Because she has schistosomiasis. That is irritation right there. She's a truck driver, sitting all day, right? Holding her urine. She's at risk for bladder cancer. So you don't waste your time with ultrasound. You go straight to cystoscopy so you can biopsy the mass, right? So a 55-year-old black female hypertensive placed on chronic hemodialysis 20 years ago for an unknown cystic disease of the kidneys presents with abdominal pain and lopsidedness. Physical examination is significant for a tender mass in the right flank. No demonstrable peritoneal fluid. The initial laboratory test is unremarkable except for hemoglobin hematocrit of 20 and 58% respectively. What is the most likely diagnosis? Hypernephroma. Why do you think she has erythrocytosis? Because of erythropoietin, ectopic production of erythropoietin, right? The hard and malignant manifestation. Okay? I hope in oncology they told you about all this systemic manifestation of oncologic diseases. You had that lecture, right? Okay, so don't forget it, it's important stuff. And they will be mixing like this. Nobody will ask you for a list. They will tell the story. That will require you to remember what those are and put them together nice and neat. Okay? Okay, let us match this one. This is a therapeutic strategy watchful waiting,
Anticipated.
palliative intention, active surveillance, with medical castration, exactly, surgical castration, orchiectomy, surgical intervention. Which of the following malignancies of the genitourinary tract is more common in white male than black? Exactly. What is the most likely diagnosis in this 30-year-old white male with an egg-sized tender mass in the right lower abdomen and absent testicle in the right hemiscrotum? Undescended testes, right? Okay, good. I think that's it. Oh, okay, one more. Which of the following, Kiara, which of the following is not a clinical feature of a low-risk prostate cancer? Low risk. D, yeah, PSA more than 20, that is too high, that is a high risk level. Okay, less than 10 is low risk. Gleason score less than 6 is low risk. Localized prostate cancer is low risk. Enlarged prostate may not even be cancer. PSA 20, you got problems. Okay, Bradley, who has the highest risk of prostate cancer? A 48-year-old black male with a total PSA level of 6 and 30% free PSA, or a 68-year-old white male with a total PSA level of 8 but 20% free PSA, or a 60-year-old Asian male with a total PSA level of 10 and a free PSA of 10%.
C.
Thank you. That is the one that you should worry about the most. Even though he has the highest level of PSA, what makes it dangerous for him is low. The free PSA is low. That is a problem. Okay? All right. Dorian, which of the following consults for urological services will elicit an urgent response? So you're putting me, where is it? Okay, yeah. You're sending this consult to urologist. Which one do you think will make the urologist jump? Evaluate and treat this 80-year-old white male with a PSA level of 8. Have you communicated clinically? No, you have not. You really have not. Evaluate and treat this 60-year-old Asian male with a PSA level of 6 and a free PSA of 6. Is that a problem?
Yes.
Okay. How about this one? Evaluate and treat the 70-year-old black male with a PSA level of 7 and free PSA of 27. Yeah. So that one is the one that will give you you'll make the guy panic. That is getting to urinary malignancies. Any questions?
Thank you.
Negative. All right. Mr. Affirmative.